The prevalence of sexual violence experienced by diverse peoples with disabilities is a cause for concern. In terms of diversity, my work has really been around using an intersectional approach, so looking at the intersections of gender and violence, but there's also other kinds of experiences as well. So all kinds of things that come together to impact our experiences. So it could be race, citizenship status, socioeconomic status, gender, ability, age, all of these things impact our experience of violence and then also our ability to seek out supports. More work needs to be done to provide accessible and inclusive supports and services for people with disabilities in all areas of life. More work needs to be done to make connections across various sectors that are involved in violence, intervention and prevention sectors. Again, there's not a lot of recognition of the intersections between disability and other aspects of identity. Tools are needed to educate and support people with disabilities on understanding their rights and how to access them. So again, with those barriers in the justice system, it can be difficult for people to even understand where to start if they want to try to pursue advancing their rights. And then also support once you're in the system, whether it's sign language interpretation or legal supports, those kinds of things. So we really do need to work together to support people in working towards addressing sexual violence, whether it's from a rights perspective or on a personal level. And that brings me to the end of my presentation. Are there any questions? I think there's some questions in the chat. There's certainly some points I could expand upon if needed.
Thank you so much for sharing your perspective with us, Dr. Berneski. I really appreciate you joining us. And yeah, you said it pretty eloquently there. And that's one of the reasons why we wanted to include the disabilities community in this speaker series, because disabilities is a societal issue. It's not, limited to any one gender or any one group. In your research and in your work, I know it's been very diverse and across the globe. What commonalities do you see in your work?
In doing my research, I was looking across contexts, and I really had to think about how am I going to do this with so many different contexts, right? And I really feel the strength of my work is the commonalities that emerged. So I think in terms of the challenges, again, it's those negative attitudes of disability. They seem to be common across contexts and cultures. There's a lot of barriers in different areas of life that can impact a person's experiences later in life. And even if you look at how different sectors work, I'll give you an example. I spoke to one participant who talked about, let's talk about transportation for a minute. So in Canada, we have accessible transportation services for people with disabilities. And in one case, a person had reported being sexually assaulted by a transit driver. And then the next day had to use that same system with the same driver to get to where they need to go. So in terms of thinking about dependency, it wasn't just in this is not directly answering your question, but I'll get there. In terms of looking at dependency, it wasn't just like in personal life, but also in transportation. We rely upon people in various sectors of life. Sorry, that's a little bit of a digression there, but in terms of commonalities, participants, all of the people I spoke to, they really expressed a desire to act. So when they met other people who had similar experiences, one of the strongest indicators of a way forward was that they wanted to work with other people to create change. And I think in terms of empowerment, again, one of the things that came out was that people felt a sense of belonging. They felt like a sense of purpose, and they felt a sense of hope in being able to kind of pave the way for other people so that they wouldn't have to have the same experiences. Yeah, so those would be the commonalities as well. I see a question in the chat about recognizing signs of abuse that might be missed. so I'm not a service provider, but what I could say is that, if you, in the research, it talks about how if a person goes to the doctor and they show signs of, they might show signs of abuse that other people might show, but perhaps the medical professional assumes that the person couldn't possibly have been abused because of those negative perceptions. And so those negative perceptions being that that people with disabilities are asexual or infantilized, so they couldn't possibly be abused. And so because you're already assuming that the person couldn't be abused, then you're not looking for those signs. So it's more about assuming that everyone is at risk, and it's not just particular groups of people. Less obvious signs particularly might be around like family abuse or caregiver abuse, because we don't often expect people in positions of care, in those care support roles, to be people that are perpetuating abuse. So I guess maybe looking for the ways in which people might interact when they're around their caregivers as opposed to when they're not, things like that. Yeah.
We have a question here. Did you do any research on abuse of Inuit living with disabilities, as they are mostly located in very isolated communities, and they're not frequently included in those statistics or adequately researched? Do you have any insight there?
So my research unfortunately didn't reach Indigenous folks in terms of the people that I interviewed. I have looked at, because I try to take an intersectional perspective, and because I do understand that Indigenous folks have experienced even more barriers, particularly because around access to services, whether it's healthcare, such as we see with Jordan's principle, the number of children who have had complex medical needs who haven't been able to access supports because of the relationship between the federal and provincial governments. I would frame that as a form of structural violence that disproportionately impacts Indigenous people with disabilities in Canada, particularly children. But in terms of Inuit living in remote locations, there has been some research in Canada on Indigenous women with disabilities in Canada, and there's a big concern around access to adequate, affordable housing and trying to leave abusive situations and things like that. So my research didn't touch on that directly, but there are certainly advocates and organizers who do work on statistics and addressing particular challenges, particularly in remote locations when it's difficult to access services anyway, or to access outside supports in very remote locations.
We have another question, and this comes from someone in the homeless sector. So they have run into barriers regarding accessibility in housing, food insecurities, etc. Have you seen an increase in assisted medical deaths due to disability?
Yes. Madeline, is that right? I feel so much passion about this particular issue. The medical assistance in dying legislation in Canada, I feel is very harmful. I feel it directly impacts people with disabilities, and some might even say it targets people with disabilities. So I'm going to say a little bit here, just checking the time. I do want to speak about medical assistance in dying, because I feel very strongly about this. I feel like it's harmful and it's dangerous, and it really, in terms of interactions with other systems, let's talk about that for a minute. Okay, so barriers around accessible and affordable housing, food insecurity. So we've seen with the pandemic that, first of all, the emergency response was the government decided to give people $2,000 in the emergency response if they all of a sudden couldn't work. What a lot of advocates for multiply marginalized people or people on income supports said as a response to that was, if in emergency, when people can't work, it's been determined that a minimum of $2,000 is needed for people to live, then that should also be the case for people on income assistance or disability assistance. We've seen that inflation has impacted the cost of transportation and the cost of food. I remember being in Toronto. This is when I first really started to look at MAID, because this was back in 2019. And the medical assistance in dying legislation removed the requirement that a person's death had to be reasonably foreseeable, which again leaves people with disabilities. So you still had to meet a list of criteria around having, a condition that isn't going to improve and that sort of thing, but your death didn't have to be foreseeable. Again, in Toronto, I was listening to the news one day, and a woman came on to the news, and she was talking about how she could no longer afford food because it had to be delivered, and because there was a lockdown, food was getting delivered, and the cost of food was going up, and then there was delivery on top of that, and she simply just couldn't afford the food. And she was worried about her housing and about the supports that she had in place. A lot of people with disabilities also couldn't have access to the care supports because of those social distancing measures and those very strict lockdowns that weren't ready to deal with very specific situations. And so this woman was applying for medical assistance in dying. And I remember feeling alarmed by that, because medical assistance in dying was meant to be for people who were dying. And their death was meant to be foreseeable, but the government decided to remove that qualification. And so there's been an alarming rate at which medical assistance in dying has been taken up in Canada. So year over year, it grows more than the year before. And so there's been an alarming number of people who've applied for medical assistance in dying and have been successful. For example, in Nova Scotia, there was a woman with multiple chemical sensitivities who couldn't find accessible accommodations that would address her chemical sensitivities. That was affordable because she was on disability assistance, and she applied for medical assistance in dying and was approved. And there are certainly people in the medical profession who offer medical assistance in dying, who say that they didn't intend to support medical assistance in dying in this way. It's not supposed to be a system that allows people, it shouldn't be easier for people to die than it is for them to live. And so I teach healthcare policy here at Cape Breton University, and what I tell my students is that we're not going to debate the ethics of medical assistance in dying. What we are going to talk about, though, is the ethics of having a policy that rapidly expands and how it disproportionately impacts multiply marginalized people. And so if you don't have the support systems in place to support people to live a quality of life, then you shouldn't be offering medical assistance in dying without giving them the proper supports to live. And so there's been, the government releases reports every year about medical assistance in dying and who uses it and whatnot, but it hasn't, to my knowledge, I haven't seen anything that says anything about the social conditions that people live in or their economic status or anything like that. And I think that really will speak a lot to inequities and it again, those harmful perceptions of disability that's the place value on particular groups of people and not others. And so again, MAID is going to be expanded again to include mature minors and also people who have a mental health diagnosis as the sole reason for applying for medical assistance in dying, which is alarming and very concerning.
Wow. Well, thank you for that. And I think you said it really well about having those programs and services to intervene before you get to a situation like that where there is no turning back from. So we have a question here from somebody that I think really, speaks to that, because if somebody who is experiencing marginalization and they have a negative experience, and then they develop a fear of being further marginalized, it may deter them from accessing programs and services that they desperately need. So one of our attendees wants to know what are some ways that those in our sector that we can implement develop that trust with the disabilities community and let them know that we are here to support them?
It's a good question. These are all good questions. So I think doing things like this session is really important, just to raise the profile of different groups so that people will see that they're not an afterthought, right? So a lot of times, especially when it comes to accessibility, I have a mobility disability. It's visible, it's physical, it's obvious, and often I feel like an afterthought when I go out places and things aren't accessible. I remember, so when I was assaulted, I was calling a support center to access counseling, and as traumatized as I was, I remember that the person who answered the phone asked me a series of questions, and then he said, do you need an accessible location? And in all of my trauma, I remember saying no, but I'm so impressed that you asked me that, because it's not a common thing that people do. If it's not a part of your process, then people can't trust you to be the person to support them. So I think having visible resources, whether it's on your website or however you're promoting your services, to include not just saying like, if you have an accommodation need, let us know, but listing some of the ways that you already know that you can accommodate people will show that you're already thinking about them and their experiences. And this might not just be, physical accessibility. It goes well beyond that to, if a person has an intellectual disability or is labeled with an intellectual disability, having things in plain language, for example, so that they can approach the services at their own level, or at each individual level. And so just making sure that what we provide to the public is really thoughtful in terms of supports and services, and so that people will look and say, oh, look, they have a list of ways that they support people with disabilities. And so I already know that I can trust them to at least have some understanding of my experience. If you can't understand everything all the time, because everybody's experience is different, but just having the planning there, I think, is really important.
Thank you. And just so everybody also knows, the Colchester Sexual Assault Centre is friendly to those with physical disabilities. So we do have the front door of our office building, which can be accessible to those in wheelchairs or mobility devices. We also have access to an elevator. There are no raised step-ups that may pose difficulty for those in wheelchairs or mobility issues as well. So we have certainly thought about those elements into our space as well.
Knowledge in this area, I think, will go a long way to make people feel more included in their spaces and in their communities. So thank you very much for your interest in the topic, and thank you for including disability in the session.